Madam, please start the program, ma'am.
Who will start?
Madam, sorry, I didn't get you, madam.
Hello?
Yes, madam.
Who will start the program?
The faculties, madam, the program RAC, right?
Yes, so means I start the first lecture straight away without any introduction or anything?
Yes, ma'am, you can start the program, ma'am.
Okay. So, good afternoon. Can you hear me? Am I audible? Am I audible?
Yes, madam, you are audible.
Thank you. Thank you. So, good evening, friends. Today we are going to learn about respectful abortion care, and I'm going to speak on module 1, which is medical termination of pregnancy amendment 2021. So we all know the original MTP Act came in 1974, and now it has been amended with great efforts from our society, from COGSI, and a lot of doctors, that the deadline that you give of 20 weeks is just not enough. Having two doctors for more than 12 weeks is not really practical, and because of that many centers cannot do the procedure. So now let us see what changes have occurred. We will take a closer look at what are the new laws and what are the changes in the rules. Before we think why we are going to talk about abortions and why change was necessary, let us find out what is the status of abortions in India. Unsafe abortions in India lead to mortality, morbidity, and hamper a woman and girl's full participation. This is really shocking that 8% of maternal deaths per year are due to abortions. 8% of maternal death. And it is the third leading cause of MMR. Nearly 2 out of 3 abortions performed are unsafe. That means only 1 in 3 is safe. And nearly half of pregnancy related deaths are in women and girls under 24 years. So, if the abortion is at a young age, that is when there are chances of losing a life much more than if the woman is older and likely to be more careful. I request all participants to please mute themselves. Now, what is safe abortion? When is abortion considered safe? It is considered safe when it is done by appropriate method and by trained person. A safe abortion as per WHO is when both the criterion are met. Less safe when either of the two, either the method is appropriate or it is given by a trained person, this 1 out of 2 criteria is met. But when both these criteria are not met, that means not by appropriate method and not by a trained person. In that case, this is termed an unsafe abortion. And as I said just now, 2 out of 3 abortions are unsafe. Medical termination of pregnancy amendment 2021. So, what is this? That safe and comprehensive care to a woman for abortion is mandated by law. Safe and comprehensive care is mandated. And now, how does it actually happen? Law, the MTP Amendment Act 2021, modification in the requirement of provider. In the previous act, there was requirement of opinion of one provider for MTP up to 12 weeks and two providers for 12 to 20 weeks. Now it is one RMP or registered medical practitioner up to 20 weeks and two between 20 to 24 weeks of gestation. What is the potential outcome of this change? What happens? There is an increase in number of facilities, especially in public sector, like PHCs, which become eligible for provision of this service up to 20 weeks. PHCs are having deliveries, but they have one gynecologist and not two, and they would be able to provide this service to people. ले जाओ बात करो. The amendment says there is requirement of only one and two only after 20 weeks. Now, what is another modification? It is for vulnerable group of women. MTP is permissible beyond 20 weeks only when it is immediately necessary to save the life of pregnant women. This was in the previous act. Beyond 20 weeks only to save life. Now it is 20 to 24 weeks for special or vulnerable categories of women. We will be dealing about what is the special, what is vulnerable category. Further enhancement for birth defects is not compatible with life on medical board consensus. Means even after 20 weeks, if you find that the baby has anomalies which are not compatible with postnatal life, you can apply and a medical board will decide that this abortion can be done, and it can be done. And it's not a never ending process because the timeline is fixed. You apply, in 3 days they answer, in 5 days the procedure has to be done. So what is the potential outcome? There is an increased access for vulnerable women to safe and legal abortion services defined by the Rules Committee, and this includes violence victims and minors among others. We'll see this in detail later. What is the modification for birth defects and congenital anomalies? As we all know, today good quality ultrasound fetal medicine specialists are available, and not all anomalies can be detected at the 20-week scan. Late onset anomalies are there and they may turn out to be incompatible with life. So now, previous act, the act had provision for termination of such pregnancies only up to 20 weeks. Now, upper gestational limit does not apply at all in pregnancies with substantial fetal anomalies diagnosed by a medical board. Now, what is the potential outcome of this? There is increase in access to safe and legal abortion services who often seek service late beyond legal limit for termination of pregnancies with substantial fetal anomalies diagnosed late, thus reducing unsafe abortions and court cases. Because if something goes wrong, we know doctor is always under threat. Now, what is the modification related to marital status? In the previous act, the condition of failure of contraceptive was applicable for only married women or her husband. Now, in the 2021 amendment, the condition of failure of contraceptive is to be extended for any woman or her partner, irrespective of her marital status. Now, what is the potential outcome? Increase access to safe and legal abortion for any woman, irrespective of marriage age. Because especially with upcoming changes in the legal age of marriage, an important advancement for increasing access to safe abortion. Then there is an insertion for new clause for strengthening the privacy. In the previous act, the Medical Termination of Pregnancy Regulation 2003 mentioned that information should not be disclosed except under authority of law. Now they say that name and other particulars of a woman whose pregnancy has been terminated shall not be revealed except to a person authorized by the law for the time being. So if somebody gets a letter that now I need to do this, that person can get it then. But if that letter is not there, it is not necessary to be given. What is the potential outcome? There is an increase in privacy and confidentiality of abortion seekers. There's an increased demand increased demand but need to safeguard rights and dignity of women and provide respectful, bias-free services, including counseling and contraception. So this, if the previous status is not known, we deal better. There is less of bias. Now, this current law prioritizes confidentiality and safety. So, name and other particulars of any woman seeking abortion to be confidential, except to a person authorized in any law for the time being in force. The ground of failure of contraceptive has been extended to women and her partner, irrespective of marital status. What are the rules under MTP Amendment 2021? It defines special or vulnerable category of women eligible for extended gestational period for termination of pregnancy from 20 to 24 weeks. The norms for the registered medical practitioner, who is a registered medical practitioner. This is defined, and the power and function of the medical board is also defined, and who has to become a member has to be defined. Rules under MTP Amendment 2021. What are the special category of women who are eligible for MTP between 20 to 24 weeks? First is survivors of sexual assault, rape or incest. Women with pregnancy in humanitarian setting, disaster or emergency situations declared by the government. Change of marital status during the ongoing pregnancy. Either she becomes a widow or there is a divorce. Women with political disabilities, women with physical disabilities, major disability as per criteria under the Disability Act. Mentally ill women, including mental retardation, minors, and the fetal malformation that has substantial risk of being incompatible with life. If the child was born, it would suffer from such physical or mental abnormalities to be seriously handicapped. So these are the 7 criteria which are included in special circumstances for women. RMP, how do you define an RMP? In the old Act, MBBS or more with any of these 4 things. Medical practitioner assisted in 25 cases of MTP, 5 done independently. Medical practitioner who has completed 6 months of house surgency in obstetrics and gynae. Medical practitioner who holds a PG degree or diploma in OBGYN. Medical practitioner who has experience of at least 1 year in the practice of obstetrics and gynae. See, this is very, very fluid. Up now, what does it say? 1 RMP up to 20 weeks, 2 up to from 20 to 24, and medical board beyond 24 weeks. An additional category of provider has been added for termination up to 9 weeks with medical methods. RMP with experience in the practice of obstetrics and gynae at any hospital for 3 months, or training with performance of 10 cases of MTP by medical management under supervision of an RMP in a hospital established, maintained, or a training institute approved for this service by the government. So 10 cases of MTP, it was previously 25, and this can be in any specialized hospital which is doing the procedure and recognized by the government. Till 9 weeks, experience and training requirement for RMP is experience at any hospital 3 months, 10 cases of MTP under supervision by medical methods. A practitioner who has assisted an RMP in the performance of 25 cases of MTP and 5 done independently. This is beyond 9 weeks. A practitioner who holds a PG degree or diploma in OBGYN, who has done 6 months of house surgency, or a practitioner who has experience at any hospital for a period of not less than 1 year in the practice of obstetrics and gynecology. Now at different gestational ages. Till 12 weeks, what is the experience and training required? 1. For less than 9 weeks, it was just 10 cases assisting. Here it is assisted and RMP in the performance of 25 cases and 5 done independently. So that had 5 categories. This has the remaining 4. A PG degree in OBGYN, 6 months house surgeon, or 1 year in the practice of obstetrics and gynecology. Beyond 12 weeks till 20 weeks, now first it was 5, then 4, now it is just 3. A person who holds a PG degree or diploma in obstetrics and gynae, a practitioner who has completed 6 months of house surgency in obstetrics and gynae, and a practitioner who has experience at any hospital for a period not less than 1 year in the practice of obstetrics and gynae. Beyond 20 weeks till 24 weeks. What is the requirement? It is the same as the previous one, but except one, now you need 2 RMPs to do the procedure. When do you need a medical board? A medical board is required beyond 24 weeks. Who can be part of the medical board? A practitioner who holds a PG degree or diploma in obstetrics and gynae, a practitioner who has experience at any hospital for a period of not less than 1 year, and opinion of medical board is required for the termination procedure when advised by the medical board is carried out with all safety precautions along with appropriate counseling at an approved place. So please understand, the medical board is required when it is permitted, all safety, appropriate person with these 2 qualifications at an approved place. All these 3 things should be there. Who is part of the medical board? A gynecologist, a pediatrician, and a sonologist or radiologist. These 3 together make up the medical board. What will it do? To allow or deny termination of pregnancy beyond 24 weeks of gestational. This would be only after due consideration and ensuring that the procedure would be safe for the woman at that gestational age, and whether the fetal malformation has substantial risk of it being incompatible with life, or if the child when born would suffer from such physical or mental abnormalities as to be seriously handicapped. Co-opt other specialists in the board and ask for any additional investigations if required for deciding on the termination of pregnancy. FOGSI with ministry guidance and WHO support as part of respectful abortion care can operationalize and host medical board information on its website. What are the rules under MTP Amendment Act? What is the function of the medical board? To examine the woman and her reports who would approach for medical termination, provide the opinion of medical board in Form D with regard to the termination of pregnancy or rejection of request within 3 days. This is very important. Within 3 days of receiving the request for MTP, and to ensure that the termination procedure, when advised by the medical board, is carried out with all safety precautions along with appropriate counseling within 5 days of the receipt of request for medical termination of pregnancy. So the board gives its answer in 3 days and the doctor has to perform it within 5 days. So this is all about the changes in the Medical Termination of Pregnancy Act. Thank you. Now you have already done the pre-test. You have to do the post-test after all the lectures are over, and the certificate will be awarded to participants on attending the training and submission of registration, pre-test, post-test and feedback. Thank you.
Madam, if we want to ask any questions.
I think I've completed before time, madam, so you can definitely ask.
Madam, the form which we are filling does not have the word that it has only 5 previous indications only. So newer forms we have to
Yes,
design.
madam. Yes, madam. Or you can write by hand.
Yes, but up till now we have printed previous pro
Yeah,
forma
in
only,
which we
so
just
that we
take,
have no.
but in that you can add, madam.
Okay, and we have to remove that was that married woman failure of contraception by married woman. We have to remove married word
Yes,
from
madam.
this.
Yes, madam.
Yes. Okay.
Thank
And
you, madam.
madam, what yes, I was asking another thing that
Ma'am, you
it
can't hear
is a
you.
3 months. Madam, I was asking that a person who has done only 10 MTPs, 25 MTPs, even if they are BHMS or BAMS, they
No, no,
can
madam. It has
perform.
to be an MBBS. It has to be an
Yeah.
MBBS. That I said in
Okay.
the first slide only. An MBBS with additional this much.
Okay. Okay.
Thank you, madam.
Thank you, madam. वो बोलती थी नहीं नोटा
Hello.
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 Hello. Hello.
Yes, madam. Yes, madam, you are audible.
Yes. Should I start my
Madam, one question.
session?
What's
Yes, sir.
Uh,
Hello. Hello. Should I share my screen?
yes.
Yes, madam. Somebody wanted to ask some question.
Madam, your net is very poor, so voice is not clear. But Dr. Jigna, should I start my
Any
session?
age proof is required for or not?
Question, Bhuja. Mother session. Dr. Jigna?
Yes, madam. Then we can start.
You are not
like,
informing me. Should I start my topic?
yes, madam, you should start that. Somebody was asking one question. That's why we were paused. I think somebody is asking that any age group, we are not able to understand the question. That we will take afterwards.
You are
We
not
can
audible,
start.
madam. I am sharing my screen. I don't know. Okay. There is the
You
MP4.
can start.
Okay, madam. Okay. I'll see you. Before you yes. Play. Well, at the outset, I'm very thankful to the organizers and the Foxy office bearers for giving me this opportunity. And I will start with the video, which is been given by, which is there from WHO.
Madam, sorry to interrupt you. Madam, this is not your presentation, madam. Yours is second topic.
Yes. I will take the second topic, safe abortion. On that, I am starting with the video which has been.
Your topic is the
Hello?
second one, technical update.
No, my topic is safe abortion and post counseling. pre and post abortion counseling. That is what is written.
According to the flyer, acha, safe abortion. Second topic, the second topic.
Yeah, so that is what I'm taking. I'm
No,
starting
this,
with the.
this is part of the third topic.
I'll share the slides, madam. Kiran madam. The second
Yeah,
topic, I'll share the
please.
slides. I'll do that. You start
Okay,
sharing
you
the
start. There might be some confusion. I'll stop with share.
Yes, ma'am, I'll do.
You start with it.
Okay, ma'am, I'll do that.
So which one? Safe abortion is the topic now?
Yes, ma'am. That is that only. But this video which you have shown is part of the
Dr.
third one.
Kirmai. So,
Yes, ma'am.
no, so let them. I'll start with the safe abortion also. Just a minute, which is the complete final one.
Kiran madam, I'll share the screen, madam.
No, is it now you have shared or I have shared?
I shared, madam.
Okay, but this is okay. Okay, you share it, right? No issue. So then please move ahead. Good evening, everybody. At the outset, I'm very, very thankful to the Foxy office bearers and the Rajkot Society and the other societies who have joined here for this wonderful program on safe abortion, respectful abortion care under the program of respectful abortion care. So please move the slides now. Yes. So this present session will have 4 parts. We will initially discuss with the existing guidelines, then pre-abortion assessment, medical methods of abortion, and finally the surgical methods of abortion. Next slide, please. Now, these are the WHO global guidelines on safe abortion, and you can see these are all available on the internet. Safe abortion, technical policy guidelines, medical method, and post-abortion contraception. Next, please. Now, basically, WHO national publications are there. So what are the roadmap to the WHO safe abortion guidelines? In 2012, post-abortion technical and policy guidelines for health system came. And then in 2014, the handbook of safe clinical practice handbook of safe abortion became available. Then in 2015, the health workers' role in providing safe abortion care and post-abortion contraception came. And then finally, 2018, medical methods for abortion guideline. And then 2019, the guidelines on self-care intervention for health regarding consolidated, these guidelines came. So anyone can see them on the net, they are available. Next. We'll be discussing the basic theories. And you all know the historic change with the and family welfare national guideline on safe abortion care. This historic change happened in 2021, which was told to you under the heading of MTP Amendment Act in detail. And their comprehensive care mandated by law came initially into 25th March. The law changed, and finally the rule changed on 24 September 2021, and they became operational, about which it has been discussed in detail. Next slide, please. Next slide, please. Yes. So the basically all the guidelines have three key areas in the management. What are those three areas? One is pre-abortion care. Second is abortion care methods. And third is aftercare and follow-up, including abortion, contraception, and counseling, which is a very important part. Now, in this, if the woman chooses to have an abortion, she should be allowed to choose from among the available methods which are there that are appropriate for her and based on her condition. How will you make this decision? That will depend on her medical history, on the physical examination, what laboratory and other investigations. Not much is required, but sometimes in certain cases, investigations may be required. And finally, discussing the contraceptive options, that is the most important. Next, please. Hello. It's a little more quick. Okay, so in pre-abortion assessment and counseling, let us see the details. Next, please. Components of pre-abortion assessment for women seeking first trimester abortions. What are they? One is a detailed history, that is always a general physical medical examination, laboratory, other investigation, and finally the decision making and procedure for counseling. Next. Next. So the just basically now this which here shows you how do you gestational age determination by LMP, physical examination. So what is happening? There is a uterine size in weeks has been done by physical examination, by pelvic and abdominal examination. So at 4 weeks, after the 4 weeks of gestation, the uterus basically starts increasing in size, and that is you all know that it goes gradually as per the rules. Then by 12 weeks, the uterus rises out of the pelvis. After 15 to 16 weeks of gestation, the uterus reaches the midpoint between the symphysis pubis and the umbilicus. At 20 weeks, the uterus reaches the umbilicus. After 20 weeks of gestation, fundal height in centimeter measured from the symphysis pubis approximates the week of gestation, which we use when we are seeing the growth of the fetus, that it becomes very important. Now, the key considerations are limitations of dating by the uterine size and physical examination are what? One, in those there information or there is fibroid, or in case of multiple pregnancies are there, like twins, triplets, etc. Or there is sometimes uterus base markedly retracted. Patient is very obese and we are not able to elicit exact fundal height, or rarely molar pregnancies. So these are the certain conditions where examination will not be problematic. There are certain conditions when the uterus can be smaller than the expected, somewhere it can be larger than the expected. Smaller if supposing the uterus is not pregnant at all, or her dating is inaccurate, or there is ectopic pregnancy or abnormal intrauterine pregnancy, patient has undergone into abortion, even she can have a missed abortion. So these are the cases where the size of the uterus will be lesser than the expected date of gestation. Then what are uterus that is larger than expected when it will be in cases if again the dating issue, supposing she was not sure, multiple gestation, the size will be more. Uterine abnormalities like associated with fibroid or molar pregnancy, of course, will give you the limitations which will happen on the physical examination. Next slide, please. Next, please. Yeah, so pre-abortion investigations, first thing you have to understand, the routine lab tests are not a prerequisite for abortion services. Now, they may be performed as per individual risk factors or according to the findings, or you feel clinically, like supposing you feel patient anemic, or you feel like you are in doubt that the pregnancy is not confirmed, then you will definitely go for urine pregnancy test. If you are feeling anemic, then hemoglobin will be done. If the rhesus testing is patient is RH negative, then or you have ABO-RH testing will tell you what is the situation. Of course, these days HIV testing after the counseling, it becomes an important part. STI screening, other laboratory tests, supposing she has some chronic disease, then you will have to test for liver function or kidney function. Normally, ultrasound is not necessary unless and until you have a doubt. Supposing you feel that the uterus is lesser than the expected date, and either you find that you feel that she is not pregnant, or you feel she has aborted, or you feel there is a topic or mixed abortion. So something like that. Then only you will go for ultrasound. Next, please. Next, please. So how will you counsel these women? First thing, you will ask thoughts about terminating the pregnancy, reasons for termination, why she's doing it, how is she, what the reason, and all what is her expectation, etc. The discussion, so that the person becomes comfortable. Then we have to inform that the early abortion is safe, so that the women is not panicky. And the trained provider is very important, because that is the criteria also. And for safely doing it, it becomes important. We discuss all available methods of abortion, risk and warning signs which are associated. Without contraception, she will get again pregnant. Even just after 14 days, she can become pregnant again. So that's very important to tell her, but that is why contraception is the need for that important. Now, when she can resume normal activities, when she can resume her sexual intercourse, all this has to be informed to her, and so that she is properly counseled. Then documentation, definitely most important is informed written consent. Once she has made up her mind, and decision to accept the post-abortion contraceptive. If she is not willing the contraception, friends, that doesn't mean that we will not provide the abortion services. Under the respectful abortion care, we will still provide it, but we will explain all the pros and cons about it. Next, please. Next slide, please. So the clinic management of abortion care, less than 12 weeks, the global recommendations are that the mifepristone and misoprostol both can be used. Misoprostol only can be done, or manual vacuum aspiration can be done. After 12 weeks, mifi and miso both, miso only, and here the vacuum aspiration is not preferred. Dilatation evacuation is recommended. Now, friends, what we learned at the time of MBBS, DNC is not recommended now, specifically the sharp curettage. So here you can see in this picture, the GOI recommendation. This is abortion up to 9 weeks. To 7 weeks, you will give initially mifepristone, 200 milligram oral tablet. We'll discuss it in further. The patient is asked to wait for 24 to 48 hours. And then the misoprostol, in fact, up to 800 micrograms sublingual, or sometimes even 400 can be given sublingually, vaginally, orally. The best is sublingual. Now, up to 9 weeks, if you go, then if you have to use the misoprostol 800 always. Next, please. Next slide. So the clinical basically are medical methods of abortion, which we call it MMA, and another is surgical, MV or EV. These are the two options which are available for the women and have to be explained. Next, please. Now, mifepristone and misoprostol, how they do act. Mifepristone is an antiprogestin and inhibits the action of progesterone. So it will interfere with the continuation of pregnancy. We all know progesterone is the most important molecule for the continuation of pregnancy. Now, initial dose of mifepristone is followed by misoprostol, which is a prostaglandin E1 analog. And this causes cervical softening, uterine contractions, and expulsion of products of conception. So initially, so together they have a synergistic action in discontinuation of the pregnancy. Next slide, please. Next, please. Advantages of tablet misoprostol are, and mifepristone, sorry, that slide. The protocols for mifepristone and misoprostol are day one, exact, which we have discussed to be in detail. Mifepristone, day one, you will give it to the women orally. And in case the patient is RH negative, the anti-D can be given. Because the bleeding will start, then the isoimmunization, to avoid the isoimmunization, anti-D 50 microgram is advocated. But basically, we all know the 50 microgram is available only at few places. So even if you have a 150, it's okay, you can give it. On the day 3, that is after 48 hours, mifepristone is administered. As I told you, up to 7 weeks, misoprostol 400 milligram, that means 2 tablets of 200 microgram can be given. Now, in case of, if the pregnancy is of 7 to 9 weeks, then 800 microgram will be used. And additionally, symptomatically, we can give, and we explain the patient, if she's having pain, she can take ibuprofen, because this misoprostol, etc., they can cause vomiting, so antibiotic can be taken. And all the time, every moment, whenever we get a chance, has to be discussed. Now, with the 15 days, follow-up is important. That time you confirm and ensure the completion of procedure and offer again contraception if it has not been already given. Now, at next slide, please. Next, please. So, what are the characteristics of different route of misoprostol and which one should be used and what is the better? Oral pills have to be swallowed. They can be recommended up to 7 weeks. Side effects will be there. That is the problem: diarrhea, nausea, fever, chills. Buccal pills are placed between the gum and the cheek and swallowed later on after 30 minutes, if already not absorbed. But again, they also cause fever and chills, although lesser than vaginal route. Sublingual. This is the best one in fact. They are fastest. These pills are placed under the tongue, and they are again after 30 minutes, they can be swallowed. Now here also, fever, chill, diarrhea, vomiting definitely can be there, but action is fastest and highest plasma concentration levels are there. So mostly they are preferred. Vaginal, that rate is better. That of course it is placed in vaginal cornices, deepest part. Here, pill fragments later on can be visible. Side effects are very, very less compared to even buccal, oral, sublingual, or. So, buccal and vaginal can be the same absorption, sublingual maximum, but the side effects are minimum in the vaginal. Next, please. So you can see here where between the gum and the buccal mucosa, the tablet has been written, and in the second one, you can see below the tongue, it has been kept. That is the sublingual. Next, please. Next, yes. So WHO drug regime, those schedule is, we have already discussed it, just the same repetition. Induced about less than 12 weeks, Mifepristone orally, misoprostol, any of the route can be there. And alternate misoprostol only if you are giving, then you are giving only 800 microgram by any route. In this category, mifepristone is not being used. Now, vaginal bleeding usually occurs for 2 weeks after medical abortion, and that is why we have a third visit at 15 days. But very, very rarely, in certain cases who are very sensitive, even this bleeding can last for 45 days also. So you have to ensure that there is no other problem. Then you can simply counsel the patient, then it will become okay. Next slide, please. So MMA services, they should be available basically at primary care center with referral systems in place, though that is the most important thing, because any time if the patient will start bleeding or have any severe other side effect like severe diarrhea or vomiting or some other problem, then the linkage to referral place should be always there to higher sector. Additional services, if needed, like counseling and testing for sexually transmitted disease. So that will be this another side work which can be done. Supportive services, psychological or social services, or other specialist or health or medical services. Now, in case patient is anemic, this is the time when we can use the opportunity to giving her the iron tablets. If she needs pain, I have already told you, ibuprofen can be given. And of course, emotional support is very, very important so that the patient, because she's getting an abortion done, we don't know what are the factors. We do have to counsel and support her. Next, please. Next, please. Yes. What we will do in a follow-up care, not that we will do and forget it. So routine, basically, a follow-up visit 7 to 14 days after the procedure may be offered, or at least I think so should be offered, because that opportunity you can assess that completion of the process is there. Another thing, take the advantage and do the contraceptive counseling. And at the same time, assess or see that if there is any other medical concern can be done. Although a routine follow-up visit is recommended in case of this about only misoprostol alone also, because many a time these cases may not be complete. Otherwise, it is also said in case of uncomplicated medical abortion, routine follow-up may not be necessary, but it should be done so to ensure the other factors. Next, please. Next, please. Assess the women's of this time. What we will do, that is the thing. Assess the women's recovery. Ask for any sign or symptoms of ongoing pregnancy. Sometimes some failure is there, so you always have to be very careful. Review the medical record and the referral document. Any symptom which has been experienced during the procedure, she can discuss with it. Focused physical examination if there is any complaint. And of course, the most important thing, again and again, the repeated thing is, we have to discuss with the fertility goals and need for contraceptive services if they have not, she has not taken it earlier. Next, please. So, to summarize MMA, next. First visit, what we have to do? Physical pelvic examination, confirmation of pregnancy, tablet mifepristone given, and TD if needed. Second thing, tell the woman to return after 2 days for misoprostol administration, her contact address, phone number, and her phone number of the facility or the center where she can go in emergency has to be shared with this. her experience has to be recorded on the MMA card. There is a very beautiful card which has been made for MMA, where in a very simple way, everything is mentioned, and that gives a clear-cut picture. Now, 3% of the women may expel completely with mifepristone alone also. But the important thing is to understand is, even if they have expelled, misoprostol should be offered so that the cleaning becomes complete and the uterus contracts. Next slide. Next, yes. So second visit, what we have to do? Give the misoprostol by any route, sublingual, buccal, vaginal, oral. Observe the patient for 4 hours. You have to tell her in the first visit only, when you will come to the next time, you will have to keep the 4 hours time with you, so that she's not unprepared for that. Then observe her for 4 hours, analgesic as per requirement, and contraceptive option discussion. And if she aborts, then they can even immediately be given, like hormonal methods, condom, oral, injectable, anything. Now, what has to be done what has to be told, that the bleeding may last for 8 to 13 days. Possible side effects: nausea, vomiting, diarrhea, headache, fever, dizziness. And in case she has excessive bleeding or pain or fever, then she will write on the MMA card and come to the center where she has to be. She's attached to that. And if there is no bleeding in 24 hours after misoprostol, then she has to come and tell you, and you can give an additional dose of misoprostol also. Basically, 75% women abort within 4 to 6 hours after misoprostol. And that is why you keep her for observation for first 4 hours. In third visit, that is on the 15th day, what all has to be done? Pelvic examination to ensure, no need for ultrasound or anything, just pelvic examination. Contraceptive options we have discussed, and we have to tell the women immediately about the immediate return of fertility, that she can ovulate even after 14 days only. So if she's not taking contraception at the moment, she has to be aware what all can happen. And she has to report back if there are no periods within 6 weeks of completion of abortion process. So how long she can wait for the next period? 2 weeks more. Now, ultrasound only if examination does not confirm the completion of procedure, or you suspect anything else, then only you do send her for ultrasound. Otherwise, physical examination will tell you that the procedure is complete. Next slide, please. So the side effects and complications are, next please. Pain, basically, respectful, non-judgmental communication is very, very important. Not that usually what happens, sometimes doctors are overburdened and they make comment like something, tu bahana bana rahi ho ya over react kar rahi ho. So nothing like that. We have to be non-judgmental and accept what she's telling. Verbally, we can support her, counsel her, and ibuprofen whenever required. I have told you, persistent pain if she is having and which is failing to respect, then we have to be become alert that there might be something else, and then look again for a topic or some infection, or there's abortion is not complete. Now, if she has other like nausea, vomiting, they are self-limiting, reassure. Rarely you might require antiemetic. Diarrhea again is a self-limiting and reassure. Of course, be careful to look for her hydration, or if something excessive is not occurring. Infection, that if it is there and you have examined, then antibiotics have to be added. Next, please. Next, please. So, if supposing a failure has happened, or after the MMA, what has to be done? That is the important thing to remember. Even counseling patient can ask this, and you have to explain. So in that case, you have to offer the vacuum aspiration. That becomes, because patient has already suffered with it, so she will agree with it. But if she says that I want to repeat MMA, you can do it. It is not that you cannot do it. Now, incomplete, then all result of MMA, you have to, how will you find out? Observe unless there is a heavy bleeding. If needed, I have told you, repeat misoprost can be given, or the EVA can be given. If the bleeding resolved, fine. Uterus is normal size, abortion is complete. If bleeding is heavy, then surgical is definitely, surgical method has to be there and abortion has to be completed. Next slide, please. So what is, if the excessive bleeding happening? Now that we have to very carefully see. Woman has presented with the heavy bleeding, even afterwards also in her menstrual cycle. She's when do we call heavy bleeding? She's soaking 2 beds in 1 hour for 2 consecutive hours. That means she's bleeding, actually bleeding heavily. Bleeding usually decreases over time. So you can counsel her and reassure her, see her vitals and observe. If she's counseled and is satisfied, she can go home and observe. But if not, her vitals or something is which is not very satisfactory, do the vaginal examination. Maybe the products are lying in the cervical canal or something, then you can do digital evacuation. Women becomes stable, then okay, again the same procedure. But if the bleeding continues, so then we have already said ultrasound might be needed here. And minimal residual bits may go themselves without a simple observation. But if their woman is otherwise stable, or if then you can do evacuation. If bleeding is, if woman is not as stable, then first stabilize and then do anything. Now, supposing if she has continued the pregnancy, then you have to discuss, and of course you have to go for evacuation. Next, please. Next slide. Now, this is become a very, very important part. This is a thing which we have not been following, and that becomes a very important. MMA basically also comes under the purview of MTP Act. So that is important. The documentation is similar to that required with the vacuum aspiration procedure. What I mean to be, there also Form C has to be filled, consent form. Form 1, where RMP opinion, that has already been discussed in the first thing. When 1 opinion and when 2 opinion, we are talking of MMA. So obviously 1 RMP here is only important. Form 2, that is a monthly reporting form, and which has to be sent to district authorities. And Form 3, which is the admission register for case 2. So these are the same forms which we mandatory for MTP. So not that it is a medical abortion. These are also have to be dealt in the same way. Next, please. So methods of first trimester abortion, besides that, surgical evacuation, MV as well as EVA. Next, please. Surgical methods are, we have already discussed that vacuum aspiration is recommended up to 12 weeks. And WHO recommends basically manual vacuum aspiration as the safest method. And it is whenever used, even in cases of previous cesarean, etc., MV is the best choice. The procedure should not be routinely completed by short puretas. In fact, when you will go, we'll go ahead, you will understand how we'll assess the completion of it. Next, please. So vacuum, let's go in a short about this. This is in the picture is showing you the assembled MVA aspirator and the cannula and the easy group cannula. it can be performed regardless of the type of the vacuum MVA. So handheld aspirator is used to generate the vacuum in MVA. In EVA, it is a different. This aspirator is attached to the cannula. They can be of different sizes, including from 4 2 millimeter and different ones up to 12 millimeter. Cannulas are used in multiple settings, including if the need be, these are like in case of EV also, these same cannulas can be used. In MVA, they will be connected to the handheld aspirator, or there they will be connected to the electric one. So easy group cannula or EPAS, they correspond with the weeks of gestation. What do we mean by? Like for 8 weeks, they have designed the cannula, which is of 8 millimeter or 8 number. For 10 weeks, 10 number. So that's how you can easily take a decision to which, depending on the size, gestational age, cannula can be decided prior which cannula you will use. Next, please. Now, in EVA, it is an electric pump which is used to generate the vacuum, and it can accommodate the same cannula which are being used for manual vacuum aspiration, and the same as per the size I have already discussed. Next. Next. Yes. Now, when we are going ahead, initially, the first step is cervical priming, and that is any gestational age, it is always better to prepare the cervix, make it soft and easy to dilate. And this naturally, the procedure becomes easy. So when cervix is easily dilated, then the chances of perforation and other complications are gone. Now, recommended methods of cervical preparation are initially in first trimester, oral mifepristone, which already discussed, misoprostol 400 microgram, which we have discussed, or misoprostol 400 milligram initially sublingually or vaginally, or the third one, the laminaria tent, placed intracervically 6 to 24 hours prior to procedure. This used to be very, very good practice, but I don't know. Somehow it has become unavailable now. Next, please. Pain management, we have already discussed. That is very, very important for quality abortion care. And to relieve the anxiety, we can use non-pharmacological like verbal anesthesia and pharmacological also. Next, please. Psychological support, we have discussed in non-pharmacological, explaining everything in advance. Procedure, doing the procedure also gently, smoothly, so that suddenly patient doesn't get pain, and encouraging her all the time, talking to her so that she's relaxed, and asking her to breathe deeply. Next, please. Pharmacological, source of pain and its management. If supposing she's anxiety, then you can use diazepam or general anesthesia also very, very rarely. Sometimes they just put their foot down. They will require general anesthesia. They will not accept any other method. Then, of course, under the respectful abortion care, you might have to give this. Cervical dilatation, although it is very, very good that if you use a lignocaine or local anesthesia, paracervical block, that's very good effective. And the NSAIDs, of course. For uterine cramping, ibuprofen X wonderfully. Now, dose and timing, if you see diazepam tablets, 10 milligram tablets are available. They can be given 1 hour prior to the procedure, or even you can give 2 to 5 milligram IV 20 minutes prior to the procedure. The duration of effect will last for 4 to 6 hours. But of course, after the procedure, patient will be slightly disoriented and dizzy also. Now, if you are using a local cervical dilatation, the paracervical block, then 10 ml, 1% lignocaine is given. 400 to 800 milligram 1 hour prior to procedure, and any NSAID can be given 1 hour prior. Only then it will become effective. Now, lignocaine will work for 60 to 90 minutes. That's a very good amount of time by which your work is completed and patient is completely out and safe. Now, NSAIDs, of course, their action lasts for 4 to 6 hours. Side effects, again, after that, patient might be feeling little dizzy, or she can have very, very rarely, if she's allergic or something, prior some issue is there which she has not told you, even seizures can occur. Gastritis with the local analgesic is quite common. We all know with the NSAIDs. Now, ibuprofen for uterine cramping, again, that is the same, 400 gastritis is there. Next, please. So, steps of MVA, that's very, very important, because now prepare the instrument, close the valve. There is actually, it is best if one can see it in the practical, but still there are 2 valves available on the side, which when you will close, then the vacuum will be created. Now, basic thing is preparation of the instrument is very important prior. So, women also has to be prepared, that we have already discussed with that about the pain control and the medication when we have to give. Ask the woman to empty the bladder. Now, cervical antiseptic preparation is done, and then paracervical block given, as we have already discussed. And so then the dilatation of the cervix is basically done with these cannula only. There are multiple, the cannula I've told you 4 millimeter to 12 millimeters. So basically, if your cervix has already been prepared, then it might not be at all needed. But if needed, you can use these cannulas only for dilated. And then there, and this MVA cannula is the adequate one which you are going to use is inserted. Next, please. Suction of the uterine, once it is prepared, the vacuum is created, the syringe is connected with it, and then suction is done by moving the cannula little bit, 1 to 2 centimeter away from the fundus, but be very careful that it doesn't come out. If it will come out from the os, if you are doing too wide movement is there, then the vacuum will go and your procedure will not be. So that is the very important thing. And sometimes even you can do a little bit of rotation in a little movement to up and down and rotation, that will help you. Once the suction, gradually the whole aspiration of the contents is done, and the tube becomes, the syringe becomes completely filled, and you can feel the gritty feeling will come. Next. So how will you know that this uterus is empty? Red and pink foam, frothy froth starts coming out, and tissue will not come out. There might be that same gritty sensation which you feel into the DNC that comes out. Cervix starts naturally gripping over the cannula because now it is contracting. Uterus is also contracting, so there might be little cramping, and then of course that movement of the cannula will become, you can feel it that the uterus has become contracted. Now, supposing you have already talked and patient has agreed that the contraception has to be, she's ready for that, then you can give at the same time IUCD insertion, or if needed, you can sterilization can also be done. Now, once the tissue has come out, observe it, check it, that is it according to the gestational age, sufficient amount of tissue has come out. So that will tell you that the your procedure is complete. And then finally, the disposal has to be done as per the as per the rules and regulations of the disposal of the instruments, they have to be soaked into the chlorine solution, 0.5%, and that will assist into the disinfection. Next, please. Post procedure, monitor her for any complication and whatever support is required. She can leave the facility as soon as she is stable, and when she's comfortable, she can sit. And when you can ensure that you have explained her, counseling has been done, the medications have to be given, all treatment has been documented, and if there's by any chance, if there's any adverse event, noted down in the facility register and the client record. Only then the patient will leave. Next, please. So the aftercare, you have to look for it. Keep the under patient or explain that patients about the post-abortion, how to follow up, and you have to look for any infection, any abortion process, incomplete bleeding, or pregnancy is not ongoing. That has to be carefully looked upon. Contraceptive option we have already many times discussed, and also have to be explained, as we discussed at the beginning, when she can resume her sexual life and the reproductive, what are her reproductive needs and how they can be met. Normally, no routine follow-up can be required unless the meso alone regime is there, because it is seen. Why? Because mifepristol, misoprostol regime combined is the almost always it is a successful MME. But in meso alone, chances of incomplete abortion are there. So according to new recommendation, here follow-up is must. Next. So to summarize, we can say, of course, that's the most important thing. India has made a historic progress, and our POXI has a great role to play into it. All the past presidents have been working into this, as we are aware of that. And finally, in 2021, this historic change could be done. Not much is done in technological update. We are doing these safe procedures and insurance, and we have to ensure the safety and quality, specifically in context to amended law and the rules and regulations, when 1 RMP, when 2 RMP, the indications, the documentation, everything has to be very carefully. We have to see, and we have to focus on respectful abortion care. That's another very thing, like a respectful maternity care concept was there. This new concept of respectful abortion care is a very good concept, and the credit goes to all the POXI office bearers and seniors. Now, every client, public, private, an opportunity to inform, educate, equip with the proper information on all the aspects. Contraception is the place. Next, please. So, thank you. And already registration and pre-test you have done. So again, I would say the post-test and feedback is very important. And of course, certificate will be awarded later on as per Fox's guideline. So any questions, friends? We can always, is there anything in the... I have Dr. Asha Jain question in this. At the moment, there is no question. If there is any question, organizers, please let me know.
Dr. Jigna,
Hello.
yeah. Can I go ahead with the third talk?
Hello, Dr. Kiran.
Hello, ma'am.
Yes, madam.
Many
Yes,
congratulations.
Thank you, ma'am. Thank you. All the best.
You are relaxed and we are under stress.
You will come
God
out.
knows.
Best wishes.
Yes,
Are we
madam, we
now
can
so at the...
start.
Yeah, I'll start because we are running little late. Thank you, ma'am.
And
for
I
this,
think the fourth again I have to take, na?
yes,
Yes,
yes.
madam.
That counseling. Okay. So you go ahead and then we'll take.
I'll not take much of time, but thank you for that very elaborate and exhaustive session, madam. So after the first topic covered the new amendments, what are the changes in the MTP law and what are the changes in the rules Dr. Asha had covered, and then Dr. Madam has covered the technical details in technical aspects in great detail. Now comes the this module deals with the respectful part of the respectful abortion care. So this is module 3, which is named as a SAVOR module, which is safe abortion values, evidence, rights, and respect. So as you all know, this is a joint FOXY and WHO initiative. Thanks to Dr. Shantakumari, President FOXY, and the entire team of FOXY. We're having this beautiful online modules covering all the societies and all our members. So this module aims to define what respectful abortion care by WHO standards is, and then highlights how the norms and stigma that we have as providers, how they can affect the services that we are giving to the pregnant women, and also what is this SAVOR module of WHO also will be dealt with. So we know that the momentum has been created, the law has changed, and this law which has changed and the respectful component of it needs dissemination and also the OB/GYN provider support. And Foxy is the best possible way how we can go ahead, because we are 37,000 and largest provider base for abortion care. And because of COVID, we all know, we are all well versed with these online platforms, and we all are learning a great deal online, and that has been taken into advantage with this module. And patient safety, you all know, respect and quality matters more than ever, and we all have a great role to play in it. So what does respectful abortion care mean? According to WHO, the definition is the safety, the care that we give which maintains safety, dignity, confidentiality, and ensures freedom from harm and mistreatment, and enables informed choice and continuous support during and after all types of abortion. This is by definition respectful abortion care, but in simple terms, it is to treat our patients with dignity, empathy, and compassion, regardless of their race, ethnicity, gender, socioeconomic status, or reproductive history. Most of the times, we may not discriminate on the basis of race, etc., but reproductive history, we do have certain ideas that the number of abortions or late abortions or unmarried status, or coming using certain medications and all. So whatever be the situation, we are not supposed to treat them with disrespect. We are supposed to treat them with dignity, empathy, and compassion. And also, as a patient, it is our right to speak up when something is not right, and also it is our right to be treated with all this. And as a provider, it is our duty to treat, to offer all these components of the care. And what are norms and stigma? This is a small video but very important video which shows how norms and what are norms and stigma, and how they can affect our care, provision of care to the patients, and how laws and policies are different from these norms and stigma. So we have to differentiate between the two, and just watch this small video so that we can go ahead with the rest of the topic.
Social norms are the unwritten rules of behavior that are considered acceptable in a group or society. Norms can change according to the environment, situation, and/or culture in which they are found. People's behavior may also change accordingly. What are some examples of social norms? In times of COVID 19, there are new social norms that are considered COVID 19 appropriate behaviors, like wearing a mask, maintaining social distance, and to wash or sanitize our hands regularly. An example of a social norm that we must follow at all times is to not use profanity in conversation. especially formal or official conversations or when talking to patients, clients. Now let's look at some examples of social norms around gender. Girls wear pink, boys wear blue. This is a gender stereotype. Girls and boys can choose to wear whatever color they like. Color has no gender. Men should be working, strong, and not show emotion. Women should be caring and nurturing and stay at home. Men should work and make money. Women should take care of housework and children. There is no need for women to own or inherit property. Now let's look at a few examples of norms around sexual and reproductive health. Just as norms around gender are smaller aspects of some broader social norms, norms around sexual and reproductive health also trickle down from certain norms around gender. According to the WHO, good sexual and reproductive health implies that people are able to have a satisfying and safe sex life and that they have the capability to reproduce and the freedom to decide if, when, and how often to do so. A woman should be married before getting pregnant and having children. Adolescent sexuality and premarital sex are unacceptable and immoral. Women are responsible for contraception. Now we see what is stigma. Stigma can be understood as a shared understanding that a person, a quality, or circumstance is somehow morally unacceptable. What are examples of sexual and reproductive health stigma? A shared understanding that sex before marriage is morally wrong and or socially unacceptable. A girl who uses a contraceptive method is promiscuous and will have problems when she decides to get pregnant. A married woman is more deserving of contraceptives than an unmarried woman. A girl who has had an abortion is committing a sin and brings shame to her community. Having an abortion has long-term health effects and the woman's health will never recover to her pre-abortion state. Women who have had an abortion once would become habitual and avoid using contraception. It is important to understand that norms and stigma are different from laws and policies. For example, an unmarried girl seeking abortion is considered immoral due to stigma, whereas, as per law, sex selective abortion is illegal in India. In this exercise, we explore how social norms and stigma influence access of reproductive health and rights, how people experience SRH stigma, the impact social norms and stigma have on our actions personally and professionally, and the impact they have on the actions of others, personally and professionally.
So that's how the norms and stigma perpetuate disrespect and abuse. And the forms of abuse or categories can be like poor rapport between women and providers, failure to meet professional standards of care, various types of stigma and discrimination, as we have seen, and sexual abuse and verbal abuse, like shouting and screaming at the pregnant women, and then very rarely, maybe in the past, something like slapping or intimidating physically also might have happened. But we should know that women have rights, and these rights are very clearly given: freedom from harm and ill treatment, right to information, protection under laws like various laws, whether MTP or POXO, then informed consent and refusal, respect for choices and preferences, dignity and quality of care. And also they have a right to timely health care and to the highest attainable level of health, liberty, autonomy, self-determination, and freedom from coercion. These are the fundamental pillars of the rights of our pregnant women. So we need to know the rights as well as what constitutes disrespect and what constitutes abuse, and what are the basic things like stigma and norms which make us kind of discriminate. So we have to understand in order to provide this respectful abortion care. And having understood this, There are 12 domains of respectful abortion care. At the cost of repeating, I'll just read out all the 12. One is again, pregnant woman has to be free from harm and mistreatment, and we always have to maintain privacy and confidentiality. We should preserve the woman's dignity and respect the choices. Respecting choices in the sense that she might be a third gravida or a fourth gravida coming for an abortion. She might not be willing to accept a contraception, or she might not be able to accept your decision or advise that better to continue with this pregnancy. So whatever it is the woman's right to choose whatever decision that she wants to take, and it is our duty to respect the woman's choices. And to do this, we need effective communication, also development of soft skills, and we have to provide proper information. And the consent has to be informed consent. It's not a blanket consent. It is not an ill-informed consent. Whatever consent we take has to be properly taken after providing all the relevant information. And also we have to provide continuous access to support systems throughout pre-abortion, then during abortion, and also post-abortion. And quality of the physical environment and resources, that is like providing privacy, maybe providing a screen, and then providing all the the quality services that the woman is due for, and providing equitable abortion care, that is allocating resources correctly, and to have competent and motivated providers. And also last but not the least is provision of contraception advice, and this has to be done without coercion. We cannot force the woman to take contraception or whatever type of contraception that we are advising, but we have to provide this advice. I think the next module, Dr. Kiran Madam again covers this. It starts from the pre-abortion, then during abortion, then immediately after abortion, and also during the follow-up visits. What all we can do is counsel and offer till the couple accepts one of the methods of contraception. And again, the 12th and most important principle is continuity of care and counseling throughout and afterwards also. Why it is important to have this respectful component is because of the change in the MTP law and the amendments. Now, instead of two providers, we are only one provider offering the abortion care for up to 20 weeks. So till 20 weeks, every patient is an opportunity for respect, and the onus is on us to do the counseling, offer the contraception, do the referral, and also the compassionate care. So it's all the more important that we become aware and learn this respectful component. And the second the change in the amendment is the 20 to 24 weeks for special cases. You know that these women are the vulnerable group, like maybe a widow, maybe a divorcee, maybe an unmarried girl, maybe a woman who is having birth defects and who could not get the abortion before 20 weeks because of late diagnosis. All these women need this extra kind of sensitivity and judgment free timely services. But most of the times this is the group of women which is not given which is not given quality and dignified care. So this is one important thing that I wanted to stress, this particular group of 20 to 24 weeks, which is very vulnerable. And again, always be mindful of the socio-cultural aspects. So what is right to us, or what is wrong to us, may be right for the pregnant woman coming from a certain socio-cultural aspect. So always keep that in mind. And again, you need to avoid stigmatizing language. So what is stigmatizing language? This video is a little bit long. I'll just go through the important points in this. Generally, we may sometimes, without much thought going into it, we may say things like abort a child. That is not a right word to say. We have to say terminate a pregnancy, and always we have to be legally accurate with the terms and terminology. And it is not better. It is better to say sex selective abortion rather than female feticides. And don't use words like get rid of this pregnancy. Why do you want to get rid of this pregnancy? Why don't you keep the child? And it is not a child. It's not yet even a fetus. So it's better to say products of conception or pregnancy. And don't use words which can hurt the pregnant woman. Don't use words like mother, father, or a child, and don't use words like recurrent abortion or repeated. Why are you coming for repeated abortions? It's better to say more than one abortion, and don't say because of the change in the amendment we may have to do abortions in later trimesters. So don't label it as late abortions. You can say at this particular gestational age or in second or third trimester abortions. And also use your words very carefully. That is very important. Whenever you are using, don't use language or words which can indicate certain kind of stigma. So then this is another video which shows the safe abortion values. That is a saver toolkit of WHO, which is available online. Please go through this module, and if interested you can play this video. Yeah, you can go online and explore this module. Those who are really
No
interested
woman should
into
die due to an unsafe abortion. And when abortion is provided, it should be given in a legal and evidence based manner with quality, safety, dignity, and respect. WHO has a toolkit on safe abortion values, evidence, and rights, or WHO Saver, which is a module based training for doctors, nurses, health providers, program managers, and really anyone to assess our values, address our biases, and learn together to transform our attitudes towards respectful abortion care for anyone who needs it. During the COVID-19 pandemic, we adapted and converted the WHO Saver Toolkit into an innovative, gamified, hybrid version that you can do either in person, online, or as a combination with an expert trainer, or simply by playing one of the standalone games to learn from the comfort of your home. Saver has 4 modules: Engage, Inform, Explore, and Equip. In the Engage module, participants review recent media stories from the country about gender, unintended pregnancy, the realities of safe and unsafe abortion, and juxtapose these with the global standard definitions. In the Inform module, participants share and discuss background information on SRHR, on safety of legal abortion, contraceptive prevalence, abortion incidence and safety, abortion law and safety, and achieving reproductive rights in the global and regional or local context. In the Explore module, participants will play various games and watch videos relating to gender, safe abortion, preventing unwanted pregnancy, explore social norms and values, and consider how these may be rooted in stigmatizing attitudes or contribute to stigma from a personal perspective. The Equip module is to promote knowledge of, interest in, and further use of WHO guidelines and tools, with a focus on guidelines and tools relevant to contraception, abortion, and post-abortion care, towards the many steps needed for achieving the Sustainable Development Goals, also known as SDGs, building resilient health systems for universal health coverage, or UHC, leaving no one behind. We must remember quality and dignity of care matter as much as saving lives. Saver is our small step towards SDGs, starting with ensuring safe abortion is provided with values, evidence, and rights or respect.
So the Saver module is available, and the game links are these. Like 1 or 2 of the examples of the games is Cross the Line or Personal Compass. We can explore what are the norms and stigma that we suffer with, what are the types of judgments that we have, what is the right thing to do globally as far as respectful abortion care is concerned. You can explore this module definitely. So coming to the almost the end, from 1970, our focus had been the elimination of unsafe abortion. We all know, we all had seen how unsafe and septic abortions could be claiming lives. Then we moved to safe abortion by 2000s, and now in 2020 it is further liberalization, respecting women's choice, going more towards human rights and women's rights, and also offering the respectful abortion. Let's have 2 recap questions. I'll project one after the other. I request you to type in the chat box the answers for these next 2 questions, so that we can make it little more interactive and can have a just revision of the things we have learned. And according to the WHO, restricting access, reduces the number of unsafe abortions. Is it true or false? Just put it in the chat box, whatever you think is right. Do we have any answers? Is it true or false? Whatever you feel is right, you can please put it. There is nothing like, we are all learning together. One answer is true. Any other answers?
False.
Go ahead. False. Thank you, sir, whoever it is. Dr. Jigna said true, and I had got one false. Shall I go forward? Okay. So actually, it is false. Because by restricting the access, we are not going to reduce the number of unsafe abortions. Actually, the contrary is true. We are going to increase the number of unsafe abortions.
Yes.
That is what we have to realize, and that is the reason why this MTP amendments have come. That is the reason why liberalization has happened. So the things which are important to consider the abortion as safe is only the place, method, and the persons who are doing, and whether the legal. I mean, that is what the three things. So definitely by restricting access, we can't reduce the number of unsafe abortions that are going to increase. And this is another question which comes into the 20 to 24, the recent amendment. She is a vulnerable group woman, as you can see. She is a widow, 30-year-old, and now because she is widowed, she wants to get an abortion, though it is 22 weeks. Now, is it your responsibility to tell her to continue? Will you do that to continue this pregnancy? What would be your advice? Do you think it is your responsibility to tell her to continue this pregnancy? Is it yes or no? Type in the chat
No.
box. No.
No.
No, very emphatic no we got. Thank you. No, no. Dr. Jigna also says no. Thank you for the answers. I think this part is very clear because, it is not our place to tell the woman. She can make her choice. We can only counsel her, talk to her, and finally it is her decision that we have to respect. What we have to remember is that we need 2 RMPs for this group, 20 to 24 weeks. That's it. That is the important thing that we have to remember. It is not our responsibility or place to tell her to go ahead with this pregnancy. So in India, abortion is legal. Now is the time to make it safe and respectful. And SAMARTH stands for Safe Abortion Made Available Respectfully Throughout Health Systems. That is what SAMARTH stands for. Thank you so much to Rajkot Society, Dr. Jigna and Dr. Dhirubhai sir and all. My presentation, I think at the end of the presentation, Shriman will post the in the chat box, so you can complete the post test and get your wonderful certificates from WHO and FOXY as master trainers or trainers for the RAC, Respectful Abortion Care. Over to you, Kiran ma'am. If any questions are there, I don't think. Yeah. There are no questions, ma'am. Carry on.
Thank you. So, Dr. Jigna, should I continue with the fourth vote?
Yes, madam.
Okay, so will you be, let us hear which one is name?
Shriman.
Yes, ma'am. Yes, ma'am.
No, I'm just sharing, I'm trying to share just a minute. Is it visible?
Yes, madam. Not full screen.
I'll do full screen. I'll do full screen. Is it okay? Shriman?
Yes,
Yes,
ma'am.
madam.
It's
Yes,
okay.
ma'am. Yes, ma'am. It's okay.
Yeah, so it is now full screen now and it is moving.
Yes, madam.
Yes, moving.
Okay. So now we go ahead with the fourth topic, and that is pre and post abortion family planning counseling. So leveraging the technology of referral online consultations that we have to discuss. Basically, pre and post abortion counseling, we have Maximum we have already discussed. About the online consultation and referrals, we'll go ahead a little bit more. So let me start with it. Basically, counseling, why so much emphasis is, you all know, in case of in the scenario of this medical legal times, we have to give maximum importance to counseling. And it is a structured interaction, basically, in which a person voluntarily receives emotional support, guidance from a trained person in an environment that is conducive to open sharing of thoughts, feelings, and perceptions. So that's a very good, complete picture. What does the counseling means? And there, it's a comprehensive picture which is there, so you can understand it. Now, there are 4 parts in which we'll discuss. One is the integral part of comprehensive abortion care. Actually, that we have discussed. Secondly, it is an important part, as important as the procedure. Thirdly, women may need help in decision making. And fourth, wherever required, the spouse should also be counseled. So help, ensure, and help. Help what? Help the woman decide about the termination of pregnancy. See, remember, but you have to help, not take the decision. This help word is very important. Help the method to choose the method, termination of method, ensure delivery of complete information and the procedure. That is the responsibility of the healthcare worker, and also help the woman to adopt a contraceptive method. So that's the importance. Now, pre-procedure counseling procedure, what are the important steps? Ensure the privacy and confidentiality, be non-judgmental and be sensitive, establish the rapport with the patient. Sometimes we have to use their own language, we have to talk their personal things so that a rapport is created. Use simple language, not the hi-fi medical jargon. Allow the women to clarify their doubts. We don't have to become irritated. Why are you asking again and again? We have to patiently counsel them. And if she has made up her mind for termination, assess her for the procedure, right? Then what is the relevance of the post-abortion, peri-abortion counseling, specifically the contraception? Because we have to tell them that there is a quick return of fertility and maximum 6 months gap before next pregnancy are required and they further plan it. And this is the opportune time for contraceptive acceptance. Also, what are the health benefits, better future pregnancy outcomes, all have to be discussed. So 90% of abortion-related maternal mortality can be prevented by ensuring contraception. That's a final advantage is. Now, pre-abortion family counseling, when we should start? First visit, first time consultation. And how you can see that there is a basket of different methods are there, and you can tell. Only thing, if sometimes patient is too upset, then you can definitely, something like that, then you can delay. We have to tell our importance of fertility. We have already told helper choices, method specific, and high risk behavior. If she's not willing, please, friends, remember that we don't have to refuse her MTP. Try and counsel each and every time. If she's not convinced, tell her to come after 1 week, again counsel. So then once she's made her decision, we have to assess the suitability for abortion and counseling. Abortion process is complete, that we have to ensure there is no infection, no injury, and fresh pregnancy has been ruled out. Everything has to be seen. Post procedure, we have to see that the women has understood the precautions and what is the care required. This is the contraception thing has been, if not accepted, again counsel, reinforce their needs as discussed. So continue to ensure the privacy and confidentiality, reassure if there is any problem, and all the procedure, the informations have to be repeated, and most specifically the danger signs. Now, post-abortion counseling depends. If she's already opted, then we have to appreciate And we have to tell her also about IUCD, MPA, etc., oral pills, what will be the follow-up protocol in any, whatever the case is, and then otherwise continuity and that card which has to be given for family planning. If supposing she is not yet opted, she's undecided, then we have to allay her anxiety. Immediate adoption and the importance of method, immediately adopting or choosing has to be explained. If she's adopting it later on, then what is the issue? Then counseling of the couple overall or the emergency contraceptive pills also, because she's not yet decided. So we have to talk about that also. Now, post-abortion contraceptive methods, what all can be? Barrier method, condoms, we all know. First abortion, when to timing is this, as soon as the sexual activity is reduced, she should take some contraceptive method. Similar is in the second trimester abortion. Additional information which you have to give that there are no hormonal side effects, can be used without consulting a health provider, easily available, prevention against STIs, including HIV, and enablement to take the responsible contraception. So whatever it is, we have to keep on explaining that. Now, secondly, supposing she has selected intrauterine contraceptive device, in that maybe 380, maybe 375. Then when inserted immediately or up to 12 days after confirmation of a completed abortion, using the surgical method, maybe it is a MMA, or inserted around day 15 of the process, provided complete POC are explained, that we have to be sure that is confirmed, and there is no infection and there is no other contraindication. Now, in second trimester, IUCD can be inserted immediately. Immediately, it can be always, or up to 12 days after the procedure. Here, there is no MMA, so nothing like that. But the same requisites are there. Additional information, it is highly effective. We have to tell them. It's a long-term contraceptive. For IUCD 375, 5 years, and for 380A, it is 10 years. So that is a good advantage that has to be explained. Now, it can be provided by trained doctors, ANMs, nurses, ANM nurses after first trimester abortion, basically, and by trained doctors only after MMA, and by PPIUCD, trained doctors after second trimester abortion. So PPIUCD can also be given. No interference with the sex, they don't interfere. Immediate return of fertility on removal is there. That also has to be told to the patient, the woman properly. And there are no hormonal side effects. That myth has to be broken down. Now, third method, it can be, she might have accepted a hormonal contraception, basically COCs. So when they can be started in first trimester immediately or up to 7 days after abortion using surgical method with MMA. With MMA, it can be started on day 3 with the dose of misoprostol or within day 15 of the process. Right? So hormonal contraception, so day 3 pe or within 15 days. Second trimester, immediately or up to 7 days after abortion, they can be started. Additional information is they also help as a non-contraceptive benefits, regulate menstrual cycles, can be provided by all health workers after first screening by trained provider, no interference with the sex, offers protection against ectopic pregnancy, endometrial and ovarian carcinoma, and benign diseases like fibrocystic and fibroadenomatosis. Not suitable for women who are breastfeeding babies less than 6 months. There we have a different type of contraception. It's a different method. Now, in hormonal contraception, there are another long-term MPA, medroxyprogesterone acetate, injectable it is. So it can also be given immediately or up to 7 days after abortion. Using surgical method with MMA, it can be started on day 3 with the dose of misoprostol. Second trimester, immediately or up to 7 days. Additionally, again, it is also highly effective. Confidentially, privacy is maintained. Nobody knows. Patient wants not to tell her mother-in-law or the other family members. Of course, well, she can do it. We have to respect that. Can be provided by doctors or Ayush, A&M, nurses after the screening by doctors for the first intention. No interference with the sex, no effect on the quality and quantity of breast milk, no estrogenic side effect, offers protection against ectopic pregnancy, ovarian cancer, iron deficiency, anemia, and uterine fibroids as per other hormones. Now, of course, permanent methods. If she has adopted female sterilization, well and good, can be performed after an abortion in the absence of, just you have to look for that there is no infection or there is no severe blood loss. So then concurrently or even up to 7 days, both Minilab or laparoscopic sterilization can be done. With MMA, it can be done only after the first menstrual cycle. That's the difference. Now, second trimester, Minilab can be performed. Here, laparoscopic is not preferred because the tubes are swollen, or it can be done concurrently or up to 7 days, or the same prerequisite has to be done. You have to explain to the council, the women, properly that it is a permanent method of contraception, of course, highly effective, immediately effective, no interference with the sex, no interference effect on breastfeeding, no long-term side effect, and offers protection against ovarian cancer. Now, in here, if any person has any doubts about the side effects, that have to be cleared by the proper counsel. Now, vasectomy, although it is less accepted in our country, but we have to counsel them that it can be it can be performed on males independent of timing and procedure of abortion because it is totally independent. It's also very effective, permanent, no other, no interference with sex or health risk. And couples should use initially, because for 3 months, the spermatogenesis, so you have to take care of this, that, they have to be careful about that. Now, so this is the same thing showing it that either it can be started on day 3 or day 15, injectable day 3, it can be given. A Sencroman also can be day 3, IUCD, day 15 you are giving, ligation can be done immediately. Then COCs, within 7 days, injectable within 7 days, Sencroman continuously can be given, IUCD can be given up to 12 days, ligation can be done at any time. So this is what about the basically counseling, and now a little bit about teleconsultation and other technologies. So there are different methods. It can be a teleconsultation, it can be telecounseling, it can be teleguidance, it can be telereference, and it can be telelinkage. So this is the byproduct of COVID, we all know. We have become much used to that. Now, these are the website and social medias which do promote various things. Helplines are available, and the patient education platforms like WHO, Ministry of Health, Family Welfare, or RCOG platforms are available, which can give the technology about it, guidelines and help how to do it. Now, teleconsultation has its own strength, weaknesses, opportunity, or threats. SWOT analysis. SWOT is COVID era. It was very important because otherwise it was not possible to see the patient one-to-one. So this saved lots of patients. Approachable throughout the process. Confidence, confidence comes. Awareness. The spread out questions answered at ease. Weakness, that one doesn't have that satisfaction of talking face to face or demonstrating, as I was feeling in the last my lecture about the demonstration of MVU. That was a little bit of, we miss it. Opportunity, of course, patient's privacy and confidentiality is maintained. This cost saving, she doesn't have to run to the doctors repeatedly. Visits are cut down. And threats are sometimes, if the patient, if the proper communication is sometimes missed, and so the misdiagnosis can be there, or some opportunity can be missed also. Now, so these like assessment can be done, confirmation of diagnosis, contraceptive need, counseling by the video conferencing, by the Zoom, follow-up. In fact, hybrid services are overall becoming more, you can say, balanced. The services facility. Patient does one visit, discusses one face-to-face, and follow-ups, like in MMH, she requires 3 visits. They can be done by the video conferencing or Zooming. So hybrid model can also work good. So the key messages finally is that we have to realize, and we have to make the couple realize, the women realize the need of post-abortion family planning, and we have to bring the couple on board and strive for 100% coverage. We have to capitalize on the basket that all the what are the contraceptive choices available, applicability in the post-abortion period, what all is available, technology like scope for entry in CSC services, policies, also you have to take care of these. There are some concern because of this. I've told you the SWOT analysis of the telecommunication. There can be some malpractices, service cost, excess. Now, one important thing here I would like to mention is adolescent reproductive health needs both online and offline, because many times they don't want to come and directly talk to you. So their online can also be helpful. And if they want offline, then that's always possible. So with this, I would again like to thank the organizers, especially our president, Dr. Shanta Kumari, General Secretary, Dr. Madhuri Patel, and all the office bearers who have developed these modules for the very respectful abortion care, and the host society and other societies for this webinar has been, very successful. And of course, as Dr. Kiran Bhai also told, after this completion of the post-test and feedback, you will be a beautiful certificate will be awarded to you, and you will also become a master trainer. So thank you very much.
Madam, I have posted the link in the chat box, madam. Post-session feedback.
Sorry?
I have posted the post-session feedback link in the chat box, madam. If you click on the link, you will be redirected to post-session feedback, answer all the questions, and certificate, madam, will issue a
The link
certificate
has
within a
been
week.
given. Yes. So all the participants, please note that there is a link into the chat box, which if you will click, then you can give the feedback. I hope we have been able to clear your doubts and tell you proper messages, key messages have been given. If you have any question, I can take it. Otherwise, we have time is there complete, so we can stop. Dr. Dhirubai, Shriman, Dr. Jigna, what is, should we stop?
No, continue.
Sorry?
Yes, we are on a screen.
Yeah, you are on the screen. So that's what I said. We have completed. And I think so, the key messages everybody must have received. We'll finally know by the feedback how well the program went. Okay. So
Okay, ठीक है.
may I leave now?
What?
Yes, madam. We have started filling this link.
You can leave the meeting also, madam. You can leave the
Oh,
meeting and you
look.
can answer all the questions, ma'am.
Shriman, can I leave now?
Yes, madam. Yes, ma'am. Yes, ma'am. कौन